I want you to try and imagine a scenario that, well, it's probably all too familiar. You are sitting in a doctor's office.
Oh, yeah?
You're wearing one of those crinkly paper gowns that never quite closes all the way in the back, right?
Never.
And the air conditioning is just blasting. You are perched on this cold examination table.
Hmm.
And across from you is a medical professional, and they're just firing off like polysyllabic medical jargon at absolute lightning speed.
Just a wall of words.
Exactly.
Yeah.
And what do? I mean, you just sit there nodding along, offering a polite, And ultimately, you end up agreeing to a treatment plan simply out of this deep sense of intimidation. Or maybe just a profound desire to not be perceived as a difficult patient.
Yeah, it is a remarkably common human experience, honestly. I mean, in that room, stripped of your normal clothes and your normal context, you are highly vulnerable.
Totally.
We default to compliance, because challenging a person in a white coat, well, it often feels synonymous with challenging the entire institution of science itself.
Which is terrifying. And that feeling of powerlessness is the exact target of our discussion today.
Right.
We are answering a very specific, very vital question for this deep dive. How can you choose your medical treatment without feeling shame, pressure, or coercion?
It's such a huge topic.
It really is. And we have pulled together an incredibly rich stack of sources today. We are talking about official guidelines from the General Medical Council, clinical standards from INTIP.
The heavy hitters.
Yeah, exactly. Plus some really profound historical insights from the landmark Cumberledge Report and practical toolkits from the NHS.
And, I mean, the mission of this deep dive is to synthesize all of those massive institutional rules into actionable intelligence for you.
Yes.
We are going to equip you, the listener, with the exact frameworks and, crucially, the solid legal backing you need to completely level the playing field in that consultation room.
To put you firmly in the driver's seat of your own healthcare, basically.
Precisely.
Okay, let's unpack this. To really understand how to advocate for yourself, we first have to kind of dismantle a very old, very stubborn cultural idea.
The whole doctor knows best thing.
Exactly.
Yeah.
That myth.
Yeah.
We need to establish that your involvement in your medical care isn't just some, polite courtesy extended to you by a friendly clinician.
No, not at all.
It is a fundamental, non-negotiable, legal and ethical requirement.
Yeah, the entire foundation of medical ethics has shifted over the last few decades.
Yeah.
And our sources point specifically to the November 2020 update to the General Medical Council's decision-making and consent guidance.
That was a big shift, right?
Huge, because historically, the medical establishment treated consent as a purely, administrative hurdle.
Just paperwork.
Right, it was an event, a piece of paper you signed right before the anesthesia kicked in, mostly just to protect the hospital from liability.
Oh, yeah, the infamous clipboard thrust at you on a gurney.
Yes. That is the perfect visual. But the GMC has made it unequivocally clear that this model is dead. Consent is not a signature on a form anymore.
What is it now, then?
It is an ongoing, dynamic process focused on meaningful dialogue. It requires this continuous exchange of relevant information that is specific to you, the individual patient.
Tailored to your level of understanding, too.
Exactly. Tailored completely to you.
And a major pillar of this updated guidance is something called the presumption of capacity. I actually found the mechanics of this fascinating when going through the sources.
Oh, it's so important.
Right. Doctors are legally obligated to presume that all adult patients have the capacity to make decisions about their own treatment unless it is legally proven otherwise in a very specific, formal way.
They have to assume you get it.
Yeah. A doctor cannot just look at you, decide you seem, anxious or overwhelmed by the jargon, and unilaterally take the decision out of your hands for your own good.
They absolutely cannot. That paternalistic approach, well, it's a direct violation of current guidelines.
Really?
Oh, yeah. And the consequences for doctors who fail to respect this presumption are severe. I mean, we are not talking about just getting a bad review on a clinic website.
Right. It's more serious than a Yelp review.
Much more. Failing to share information or ignoring a patient's concerns can lead to formal complaints, serious physical harm to the patient, and ultimately sanctions against a doctor's fitness to practice.
Wow.
Yeah, a clinician's very license to practice medicine is tied to their ability to treat you as an equal partner in decision-making.
It sounds like we're moving from a dictatorship to a democracy in the clinic room.
That's a great way to put it.
Which sounds wonderful on paper, but I have to push back here for a second.
Go for it.
Don't we go to experts specifically because they know more than us? I mean, they endured a decade of grueling medical school and residency.
True.
Isn't it just easier and frankly safer to let them decide? Like, if my house's foundation is cracking, I don't want a shared decision-making process with the structural engineer. I just want them to fix the concrete, you know?
That is a totally understandable reflex.
Ugh.
But the human body is infinitely more complex than a concrete foundation, and the outcomes are far more subjective.
Subjective how?
Well, what's fascinating here is the data surrounding this. It's truly eye-opening. Studies consistently show that when left to their own devices, both patients and clinicians overestimate the benefits of medical treatments.
Right. Both of them.
Both. And they both underestimate the harms. We all share this built-in optimism bias about medical interventions.
I guess we all want the magic pill to exist.
We desperately want it to exist. But the evidence shows that when patients actually participate in true shared decision-making, meaning they fully grasped, the real-world mathematical odds of success weighed against the actual side effects.
What happened?
They frequently choose less hospital care.
Really?
Yeah, they opt for less invasive options. And crucially, they report far better overall experiences and much lower rates of regret.
Oh, wow.
Because think about it, your structural engineer doesn't have to live with the physical pain of fixing your house, but you have to live with the daily side effects of a medical procedure.
Wow. That reframes the whole dynamic.
It really does.
So now that we know we have this ironclad legal right to share in the decision, how do we actually exercise that right? I mean, sitting in a 10-minute appointment, watching the doctor subtly glance at the clock on the wall.
The worst feeling.
It is so easy to freeze up and forget everything you wanted to say. We need a system to fall back on, don't we?
Absolutely. Relying on sheer willpower in a high-stress, time-compressed environment rarely works. You need a cognitive shortcut.
Right.
A standardized way to interrogate the options in front of you.
And the sources provide a really brilliant tool for this from the Choosing Wisely UK initiative. It's an acronym, right? BRANO, B-R-A-N.
Yep, the BRAN framework.
The literature says these are the 4 questions you should always ask when presented with a new test or treatment. Can you walk us through how a patient actually uses this in the room?
Gladly. Let's break them down. The B stands for benefits.
Okay.
So when a clinician suggests a procedure, you ask, what are the actual benefits of this to me? And you want specific data here, not just vague assurances.
Like asking for numbers.
Exactly. Or asking, will this cure the issue, or is it just going to manage the pain?
Got it. And the next one.
The R stands for risks. You ask, what are the chances this intervention actually fails? What are the common side effects? And how might they impact my specific daily quality of life?
That makes sense. And then we move to the A, which stands for alternatives.
Yes. You ask, are there other treatment options? Which ones should be tried first?
I feel like doctors don't always volunteer that information.
They don't, and this is vital because the BRAN framework explicitly acknowledges that there's almost always more than one way to treat a biological problem.
It kind of shatters the illusion that the doctor's first suggestion is the only narrow path forward.
Exactly.
Here's where it gets really interesting, though. The final letter, N, which stands for nothing.
Yeah.
As in, what if I do nothing? I have to admit, doing nothing sounds absolutely terrifying when you are sick.
It does sound counterintuitive.
Right. When you go to a doctor, you want action. You want them to fight the illness. Is doing nothing really a viable medical option, or is it just a way to delay the inevitable and make things worse?
It is a highly viable option, and asking the question is an incredibly powerful diagnostic tool.
How so?
Doing nothing, which clinicians often refer to as watchful waiting or conservative management, it establishes a crucial baseline for comparison.
Oh, I see.
Yeah, you are basically forcing the clinician to articulate the natural trajectory of the illness.
Mm-hmm.
You have to ask, like, how will my condition change if I don't have treatment right now?
Yeah.
Will it naturally resolve? Will it just stay the same?
So it forces the doctor to admit if a condition isn't actually a ticking time bomb.
That is the core of the issue. It prevents unnecessary overtreatment. Because every single medical intervention, from a simple blood draw to major surgery, carries risk.
Okay.
If a condition isn't likely to worsen, or if the side effects of the treatment are demonstrably worse than the disease itself, doing nothing might actually be the most evidence-based, medically sound choice you can make.
Yeah, that's a wild thought.
And remember, choosing not to have treatment today does not mean you are permanently barred from changing your mind tomorrow.
Right. You're just waiting.
Exactly. BRAN honors the fact that your lay expertise, knowing your own body, your risk tolerance, your lifestyle, all of that must be weighed on the exact same scale as the doctor's clinical expertise.
Lay expertise. I love that term.
That's a good one. Right.
It validates our lived experience as actual data. But, even with the brand questions written down in a little notebook, actually opening your mouth and speaking up can feel deeply socially awkward.
Oh, absolutely.
We have to look at why we feel this reluctance to speak and how to bridge that confidence gap.
Well, the psychology of the patient experience is a major focus in our sources. The NHS Scotland campaign called It's OK to Ask tackles this head-on.
What did they find?
They identify the primary psychological barriers that keep patients quiet. First, patients simply don't want to take up a busy professional's time.
Oh, I felt that.
We all have. They see the crowded waiting room, they know the healthcare system is strained, and they just feel guilty.
They feel like an inconvenience.
Exactly. Second, they fear looking stupid by asking for clarification on complex medical terms. And third, they default to this deeply ingrained social script of just wanting the authority figure to tell them what to do.
It really reminds me of taking your car to a mechanic.
Yes, perfect analogy.
But instead of just nodding along when they start throwing around terms like catalytic converter and oxygen sensors because you don't want to look clueless, you actually need to ask them to physically show you the broken part.
Yeah.
You need to ask what happens if you just drive the car as is. Because when it's your body, blindly nodding along is dangerous.
It is.
So how do we practically get past this intimidation? The sources mention these things called NICE patient decision aids, or PDAs.
Yes, PDAs are fantastic.
And just for context for the listener, NICE-E is the National Institute for Health and Care Excellence, which provides national guidance to improve healthcare. But how do these PDAs physically work to prevent us from feeling like we're taking, a pop quiz on biology?
Well, the beauty of a patient decision aid is that it removes the need for you to be a medical expert.
Okay, how?
They are tangible, evidence-based tools designed for specific conditions, whether that's deciding to take statins for cholesterol, managing type 2 diabetes, or choosing between breast cancer treatments.
What do they actually look like, though?
Physically, a PDA is often a literal printed grid or a digital chart that you look at alongside your doctor. It maps out columns of available treatments against rows of likely outcomes, benefits, and harms. And it's all in plain, accessible language.
I noticed in the NICE's guidelines, it explicitly says these aids do not advise people to choose one option over another.
No, they don't.
They don't have a hidden agenda pushing you towards surgery or away from medication, right?
Yeah. They are completely neutral. If we connect this to the bigger picture, they are fundamentally value clarification tools.
Value clarification.
Right. They take complex population-level medical data and help you map it onto your highly specific personal life. They force you to figure out what you actually care about.
Give me an example.
Sure. So, for instance, if you were looking at a PDA for a joint issue, you might realize, looking at the grid, that you are far more terrified of a surgical infection than you are of doing 6 months of intensive physical therapy.
Yeah, that makes sense.
There's no wrong answer, only the answer that aligns with your life. Using these tangible tools is how we achieve the ultimate goal of shared decision-making, arriving at the right management at the right time for that specific person.
That makes perfect sense when you and the doctor are just looking at a piece of paper together, but that brings up a slightly more complex layer of this whole discussion.
Uh-oh.
Yeah. Sometimes the pressure to choose a certain treatment isn't just internal intimidation. Sometimes that pressure is coming from subtle external forces acting upon the clinician themselves. To make a truly free choice without coercion, you kind of need to understand the environment your doctor is operating in.
That's a great point. Healthcare does not exist in a vacuum, It operates within strict economic and commercial realities.
So what are the rules there?
Let's look at the GMC's Good Medical Practice Guidelines, specifically Domain 4, which covers trust and professionalism.
Okay.
This domain heavily regulates how doctors can advertise their services, which they must balance alongside the general rules of the Advertising Standards Authority, the ASA, and the Committee of Advertising Practice, or the CAP.
Okay, alphabet soup. Why do those advertising bodies matter to a patient sitting in an exam room?
Because the rules they enforce dictate how medical treatments are actually sold to the public, particularly in private practice. The guidelines are extremely clear. Doctors and clinics must not make unjustifiable claims, they cannot guarantee cures, and most importantly, they must not exploit a patient's vulnerability or their lack of medical knowledge to sell a service.
And the sources noted this is especially dangerous in private practice clinics. I mean, patients might be walking in with chronic pain, desperate for a solution, and holding a credit card.
Exactly.
It's a prime environment for exploitation if marketing makes promises the medicine can't actually keep.
The commercial pressures are very real there.
Yeah.
But, systemic pressures exist in the public sector as well.
Really? Like what?
Well, we reviewed guidance from the British Medical Association, the BMA, regarding competing interests and financial incentives. Public health services everywhere are under massive pressure to make efficiency savings.
Budgets are tight.
Very tight. And because of this, local health authorities sometimes offer financial incentives to doctors or clinics to prescribe more cost-effective medicines, or to tightly manage their referral rates to specialists.
Okay, let me stop you there, because the mechanics of this are wild to think about.
It's intense, I know.
Are we saying a local health trust might pay a bonus to a doctor if they switch their patients to a cheaper brand of medication? Are doctors being subtly incentivized to act like upselling car salesmen? Or worse, denying us specialist care just to hit a clinic budget target?
It is a startling concept to confront, honestly, but we need to look at it analytically. The BMA guidance doesn't frame all of these schemes as inherently malicious.
How so?
Efficiency savings are often about vital resource management, ensuring that a publicly funded system doesn't just collapse under its own financial weight.
Fair point.
If a local health authority encourages doctors to use an equally effective but cheaper generic blood pressure drug, that is just good stewardship of public funds. We shouldn't demonize clinicians for operating within a necessary budget.
But there has to be a line, right?
Yeah.
Where resource management crosses into compromised care.
Oh, absolutely. There's a very bright ethical line. The BMA rule firmly states that a doctor's primary overriding obligation is always to the clinical well-being of the specific patient sitting in front of them.
A patient comes first.
Always. A doctor must never put pressure on a patient to participate in a treatment plan just because it yields a financial benefit or hits an efficiency target for the clinic.
Right.
Furthermore, if a doctor believes that a local cost-saving policy is actively putting patients at risk, they have a professional duty to blow the whistle and raise those concerns.
So the practical takeaway for you, the listener, is situational awareness.
Yes.
Knowing that these systemic economic pressures exist empowers you to lean even harder on the brand framework we talked about.
Yeah.
If a doctor suddenly suggests switching your long-standing medication, asking, what are the benefits to me specifically, and what are the alternatives, ensures the decision is being made for your biology, not for a clinic spreadsheet.
Perfectly said. It forces the conversation out of the macroeconomics and right back to your individual health outcomes.
Okay, so we've covered the legal shifting consent, the brand acronym, the decision aids, and these hidden economic pressures. Let's look at how all of this plays out in real-world high-stakes situations.
This is where it gets heavy.
It does. The sources spend a lot of time on what they call preference-sensitive decisions. These are medical crossroads where the right choice is entirely subjective, and historically, a failure to utilize shared decision-making in these areas has caused unimaginable harm.
The fields of urogynecology, which deals with pelvic floor disorders and incontinence and menopause management, are prime examples highlighted in the text.
Let's talk about that.
Yeah, let's take issues like stress urinary incontinence or pelvic organ prolapse. The medical data shows that there is often no clear objective superiority between undergoing surgery and opting for non-surgical routes, like, say, intensive pelvic physiotherapy.
So the scientific evidence is essentially tied.
Exactly. The success of the treatment depends entirely on how the patient defines success. And when that patient preference is ignored by a paternalistic medical culture, the results are catastrophic.
This was the Cumberledge report, right?
Yes. This was the central finding of the Cumberledge report, which was titled First Do No Harm. It was a landmark independent review in the UK that investigated reports of immense, life-altering harm suffered by women who were implanted with vaginal mesh devices.
That report it's chilling to read. The sheer scale of the suffering is hard to comprehend.
It is a watershed document in medical history. It detailed how the medical system completely failed to listen to patients.
How did they fail specifically?
Doctors didn't ask women about the impact of the mesh on their daily functioning, their chronic pain levels, or their sex lives. When women reported debilitating pain, it was often dismissed as normal or psychosomatic.
Which is horrifying.
The report proved conclusively that a systemic lack of collaborative decision-making, combined with the dismissal of women's reported lived experiences, led to tragic, widespread consequences.
Because the patients weren't heard.
Patients weren't fully informed of the risks, and their personal quality of life preferences were never centered in the consultation room.
And we see this vital need for preference in menopause treatment as well in the sources.
Very much so.
They point out that simply discussing alternatives like lifestyle changes or natural remedies alongside hormone replacement therapy drastically improves a patient's satisfaction.
Just having the conversation.
Exactly. Just knowing the options exist and mapping them to a patient's daily life, even if they ultimately choose HRT anyway, significantly reduces decision regret.
Absolutely.
So what does this all mean? When the medical evidence doesn't point to a clear winner, how does a patient weigh the scales without feeling completely crushed by the responsibility of making a complex medical choice?
This raises an important question, and it goes right back to the core philosophy of our entire deep dive. When the science is tied, you are the tiebreaker.
I love that. You are the tiebreaker.
This is precisely why the concept of patient expertise is half of the equation. You are the world's leading, foremost expert on your own life. You are the expert on your own tolerance for risk.
Only you know what you can handle.
Right. If a 10% chance of a surgical complication is an absolute deal breaker for your career, or if it's, an acceptable risk to get back to playing sports, the doctor cannot weigh those scales for you because they do not live inside your body.
That reframes the entire burden of choice. It removes the pressure of feeling like you have to figure out the medically perfect answer and replaces it with the freedom to make the choice that simply aligns best with your values.
It transforms the consultation from a lecture into a genuine partnership.
What an incredibly empowering journey this has been. To briefly recap for everyone listening, we have established that medical consent is an ongoing dialogue.
Not a quick signature on a clipboard.
Right. You have a legally protected right to be deeply involved in your care. You should always walk into a clinic armed with the brand framework, asking about the benefits, the risks, the alternatives, and the baseline option to do nothing.
Don't forget the nothing.
Exactly. And you have regulatory bodies protecting you from commercial advertising pressures and financial coercion.
But most importantly, you need to remember that your personal values, your daily lifestyle, and your individual fears are just as vital to a successful treatment plan as the doctor's clinical expertise.
That is so key.
Your voice is a necessary medical instrument. If you don't use it, the system operates blindly.
You never, ever need to feel shame for taking up a professional's time. You never need to apologize for asking them to explain things without jargon or for exploring every single alternative. You are half of the partnership.
I want to leave you with a final provocative thought to mull over. We are entering an age of unprecedented, rapid medical advancement.
We really are.
Soon, we might have dozens of potential, highly targeted treatments for every single ailment. And if that is the case, is it possible that the most important life-saving medical skill of the future won't be a doctor's ability to prescribe the right pill, but simply their ability to sit down, look you in the eye, and ask what a good life actually looks like to you?
That is a brilliant question to end on. Because if they don't know where you want to go, they can't possibly help you get there. So the next time you find yourself sitting on that cold examination table, wrapped in a crinkly paper gown, remember, you are not just a passive recipient of healthcare. You are the expert on you. Speak up, ask your questions, and take the wheel.